Good morning, good evening, good afternoon, everyone, depending where you're joining from. Happy Sunday. Today, we're very lucky to be joined by Dr. Sumit Mohan today to talk to us about the challenges of disease donor kidney utilization.
Great. Thank you, Ayman. And thank you for the invitation. So the challenge I have today is to describe kind of the challenge of deceased donor kidney utilization, which, as many people in the audience might know, has become a major challenge in the United States with a very high discard rate. But given the international audience, I'm going to spend less time today talking about the allocation and system design issues in the United States, which I think are potentially contributing to our challenge, and speak more from a clinical perspective. But happy to take questions at the end regarding system design issues. These are my disclosures. Nothing that's particularly pertinent to what we're going to be talking about today. So I want to start with this idea that every system is perfectly designed to get the results it gets, right? So this is as an important construct as we think about what it is that we're trying to do and why we're trying to do what we're trying to do. Especially when you think about a deceased donor kidney transplantation in any part of the world, is the function of it. You have to make choices, you have to make trade-offs in terms of trying to make sure that we're able to get patients transplanted. And I think this idea that design choices matter was probably best, defined for us by behavioral economists, right? So this is, if you haven't read this, this is a fantastic book by Richard Thaler, who's a Nobel Prize-winning economist for his work in behavioral economics, which basically, the central tenet of this is the idea that humans don't necessarily always make rational choices. In fact, we make many of our choices that are irrational and a function of kind of the how a system is designed and what the choice architecture is that we're offered to, right? So just as a quick aside in terms of what that actually, how does that translate into what we do? So as an example, this is a question that at least if you've been to the DMV to get your driver's license in the United States, you've been faced with this question, which is, in the event of my death, do I agree to the donation of my organs, yes or no? And I would hope that the majority of us on this call today would say yes, but I can certainly see a significant number of people saying no to this sort of question. Now, if I don't change the question, but I precede the question with this other question that says, I would want an organ transplant to save my life if I needed one, yes or no, you can see what I've done is I've changed the context. I have not actually changed the second question. I haven't changed anything about it other than the context. And this is the idea of, choice architecture, where you do this, how you do this, what the context is that you're faced with choices can have dramatic impacts in how you make decisions. And so this was an experiment that my former chair of medicine did about 15 years ago now with medical students. And we went from a 70-30 break of yes, no, for people who wanted to donate, to 100% saying yes, right? So clearly this is just one example. If you read any of the works in behavioral economics, you'll recognize that there are lots and lots of examples of this, and healthcare systems are now using this idea that you can nudge people to make better choices in many ways. Okay, coming back to what we were talking about today, which is kidney transplant. So just as a reminder, end-stage kidney disease patients have a dismal outcome, right? If you leave patients on hemodialysis, we really have not changed 5-year survival rates in a meaningful way in the United States for over 2 decades. We're still at about 40%, which is an annualized rate of 20% or more, which is worse than most malignancies. It's starting to approach that of CNS malignancies, which is quite dismal. Outcomes, however, are dramatically better for those individuals who receive a kidney transplant, be it a living or a deceased donor transplant. Another way to think of it is if you look at the Medicare population, the dark blue bar here represents the dialysis population, right? Many-fold higher deaths per 1,000 patient years than the general Medicare, age-matched general Medicare population, which is in the orange bar. Now you go ahead and give these individuals a kidney transplant, and you can see a dramatic drop-off in mortality rates where it starts to approach that of the general Medicare population. Another way to think of this, and perhaps I think the most telling way to look at it is, this is data from the most recent annual data report from USRDS, which shows